مساء الخير. I'd like to welcome you all here today. This is the last session of our pathology workshop program. The 2023 HER2 testing guidelines update in breast cancer, HER2-ish in focus, presented by Prof. Dr. Iman Gouda, NCI Egypt. Thank you, Doctor.
Assalamu alaikum. HER2 testing in breast carcinoma, there has been. The laser pointer. Okay. Okay. There has been a new guideline published May of this year on HER2 testing in breast carcinomas. Needless to say that the breast cancers form a burden in the health system and in the cancer care, because it's around 30% of cases in females, and the death from breast cancer forms around 10% of deaths from in cancer patients. This highlights our role as pathologists in the management of breast cancer patients, especially in the era of precision medicine and targeted therapy, where we try to treat the patient with a drug that fits the disease and not a drug that fits all diseases. So according to the pattern of expression of the genes in the patient, and according to the biological profile of the tumor, the drug targets the necessary genes to treat the patient. And here comes the role of us as pathologists to ensure that the right drug is delivered to the right patient by using what's called as a companion diagnostic. A companion diagnostic is a biomarker that has the predictive role to tell that the patient will or will not benefit from that drug. And of course, molecular testing has expanded in the current era to involve several areas in the pathology: classification of tumor types, identifying hereditary risk factors like BRCA1 mutations in breast cancer and ovarian cancer, targeted therapy, prognostic risk scores, and predictive biomarkers. So our focus today is on the HER2 gene. So the HER2 gene encodes for an epidermal growth factor receptor, the human epidermal growth factor receptor located on the cell membrane, which when overexpressed leads to activation of the cell signaling pathway through activation of the tyrosine kinase. So when the situations are, the environment is suitable, there is a process of dimerization of the receptors on the surface of the cell, on the cell membrane, and this leads to the activation of the cell signaling, leading to cell division and cell growth. And of course, for this process to start, there has to be an overexpression of the gene. So what does Herceptin do? Herceptin is a monoclonal antibody that binds to the extracellular portion of the HER2 gene. So it prevents the process of the dimerization of the receptors and therefore prevents the cascade which leads to expression of growth factors and thereby arresting the growth and the cell division. And it also induces apoptosis through antibody-dependent cellular cytotoxicity. all new tumors should be tested. All new breast cancer tumors should be tested for HER2. Also, patients who then develop metastatic disease must have a HER2 test performed in a metastatic site, of course, if tissue sample is available. The reporting of the HER2 usually is on the larger invasive tumor, and when it is necessary, we can also consider a comment if there is a heterogeneity of the tumor, or if there are multiple tumors that show different biology. And as Professor Nadia Mukhtar outlined earlier this day, that we need to have adequate cores for the assessment of the HER2 status. If we're having the biopsy is in the form of fine needle aspiration, for example, if we cannot take a tissue biopsy in a metastatic disease and we're having a fine needle aspiration, it's better to do cell block and to perform the HER2 status or HER2 study on the cell block. If we have to perform it on a liquid-based cytology, it's better to use the ISH, because the ISH outlines the signals in the nucleus and not the cell membrane as the immunohistochemistry, and that's much easier to interpret in the cytology samples. Also, in metastatic bone lesions, it's better to do the ISH, because the decalcification techniques for the bone, they affect the immunohistochemistry more than the in situ hybridization. So, going back to the 2023 HER2 testing guideline, did the HER2 testing algorithm change in the 2023 ASCO-CAP, the American Society of Clinical Oncology, and the College of American Pathology recommendations for breast cancer? And the answer is no. It did not change from the 2018 guideline, and the algorithm is reaffirmed in the new guideline, but with certain recommendations. So it's the same algorithm for the immunohistochemistry HER2 testing in the new guideline. So what has changed, or what is the recommendation? The recommendation is that it's the best practice for the pathology labs to distinguish immunohistochemistry 0 score from 1+, and that's because this update acknowledges a new indication for the drug, the anti-HER2 antibody, when HER2 is not overexpressed or amplified, but is immunohistochemistry 1+ or 2+, again without overexpression or without amplification by in situ hybridization. So this drug, this new antibody drug conjugate, trastuzumab deruxtecan, is fit for patients who are HER2 negative, but they are score 1+ or 2+, not amplified by CISH, but it's not fit until now for the score 0. And that's why it is necessary to differentiate between score 0 and score 1+. Yes, we will report the result as HER2 negative in the end, but we will have to add a comment. And the new HER2 testing reporting comment provided by the ASCO-CAP recommendations is as follows. Patients with breast cancers that are HER2 immunohistochemistry 3+ or 2+ ISH amplified may be eligible for several therapies that disrupt HER2 signaling pathways. Invasive breast cancers that test HER2 negative either 0, 1 plus, or 2 plus-ish not amplified, are more specifically considered HER2 negative for protein overexpression gene amplification, since non-overexpressed levels of the HER2 protein may be present in these cases. Patients with breast cancers that are HER2 immunohistochemistry 1 plus or 2 plus-ish not amplified may be eligible for a treatment that targets non-amplified, non-overexpressed levels of HER2 expression for cytotoxic drug delivery. And this means that the immunohistochemistry 1 plus is still biologically, it's the same as the immunohistochemistry 0. It's not a new entity. There is no, they did not approve the new HER2 low category. They did not approve this term, but they approved and they acknowledged that these patients who do not have protein overexpression or gene amplification, but they show the incomplete membrane staining in over than 10% of the tumor cells, yes, they can benefit from the new drug. Okay, so it's the best practice effort to distinguish that, as I said, immunohistochemistry 1 plus results from 2 plus, from 0, I'm sorry, by, of course, examining the high power, by having the proper controls, including those with 1 plus, and proper pre-analytic conditions, as was covered in previous sessions. So, coming to ISH, do we have to do ISH for immunohistochemistry 1 plus? No. Because immunohistochemistry 1 plus means that there is no protein overexpression, but simply, according to the clinical trials, it can benefit from the drug. Okay, so coming to ISH, the in situ hybridization measures the HER2 gene amplification by using a dual probe. One probe targets the HER2 locus on the chromosome 17, and the other probe targets the area of the centromere. The HER2 probe is detected by black signals on the slide, and the centromere probe is detected by enzymes showing the chromogenic red signals on the probe. Very important, never examine an HER2-ish slide without the HER2 immunohistochemistry slide alongside by side. It's very important because it will direct you to the area you need to examine in the ISH, and it will give you a perspective of what you can see in the ISH, and if there is any kind of quality control problem, because if I'm seeing, for example, an area in the immunohistochemistry that is near to 3 plus, and then I find the ISH to be no signals or very low signals, maybe there is some problem. And I have to examine particularly this area on the immunohistochemistry slide that is near to 3 plus to assess if there are amplified signals or not. Maybe the technician wiped out this area while cutting. I have to make sure of this so as not to give a chance that, or not to make the patient lose the chance of having the proper therapy. So very necessary to have the immunohistochemistry slide as a guide map. And usually we use the signals in the internal positive control. The internal positive control is usually the normal cells present in the slide, like the stromal cells, or like the endothelial cells, like the lymphocytes. We use the signals in these cells as a reference to the size of the signal. So, for example, if I want to say that I'm having a cluster, which is the least is 6 times the size of the signal. So my reference signal is the signal in the internal positive control in the stromal cells, endothelial cells, lymphocytes, normal ductal cells. So these are the internal controls that I use as a reference. And we usually count HER2 and chromosome 17 copy numbers in 20 representative separate nuclei. They have to be separate. So I have to pick a separate nucleus, okay? And it has to have at least one red signal and one black signal. I should not go to something like this, which are overlapping nuclei, because sometimes these signals come from the overlapping of the nuclei, so I have to have the separate cells. I'll go back to the previous slide just to show the internal control cells here. They are the stromal cells with the signals. And usually we use either a 20 objective, 40, 60 objective, according to the size and number of the signals, but usually 40 is fine to assess. And at least, as I said, 1 to 2 copies of HER2 and chromosome 17 signals are present. We should avoid truncated or over-digested damaged nuclei, the nuclei with the air bubbles. Usually we ignore these, and we avoid abnormally large nuclei because, as I said, they might be more than one nucleus actually. And we usually count the doublets as a single signal. Sometimes the signal, like something like this, they are both two attached together. Here we can find a little bit separation, but sometimes they are very attached to one another. If they are attached to one another, like this one, we count this as one signal. This is called a doublet. Okay. A cluster, as I said, is defined as numerous overlapping signals in the nuclei that cannot be individually discerned. In order to assess if this is a small cluster or an intermediate cluster or a large cluster, usually the small clusters are about the size of 6 reference HER2 black signals. If it's larger than this, double this, it will be a large signal, 12 signal, and maybe even you can multiply up to 24 signals according to the size of the clusters. So here's a question for you. How many cells can you count in this slide are proper for counting? Do we have an answer? Yes? Huh? Bravo. It's around 15, they are in around 15. So thank you, Ian. Okay, so, and this is the algorithm for the ISH testing, and it has not changed also as the algorithm for the immunohistochemistry testing. And usually the positive, the positive is the group 1. When we have an average HER2 copy, that is the black signals, equal to or above than 4, and we have the ratio between the HER2 signals and the red signals or the chromosome 17 signals equal or more than 2. In this case, it is considered amplified or positive. On the other side, if the ratio is less than 2 and the copy number is less than 4, then it is considered negative or not amplified, and we issue out the report and there is no additional workup needed. What about the other scenarios? We have group 2, group 3, and group 4, and we will come to these now. So before we go to group 2, 3, and 4, let's see some slides. And it's also for you to tell me, what do you consider this slide? First, is it adequate? Can we count it? Do we have a proper number, يعني an acceptable number of separate cells to count? Are the cells fixed in a proper way? And if it's amplified or not? Countable? Countable. Okay. Amplified or non-amplified? Amplified. Clusters or no clusters? Clusters. And the clusters here, I'm sorry. We can, the pointer. No, sorry. So the clusters here we can see small clusters, okay? And we have also like intermediate clusters here. يعني intermediate, I'm saying it's double. The 6, we can call this 12 signals. This is a relatively large clusters. And if we were having more than this, it can come up, as I said, to 24. But here, most of the clusters are small clusters. We have few large clusters. And of course, we have the red signals present. What about this light? Is it countable? Is it amplified or not? Countable? No? Yes, there are overlap, but we can find برضو separate cells. يعني we have separate cells here. Separate. We have separate cells. It's countable. Amplified or not? Not amplified. Yes. Of course, we need to count, but if I see that, يعني by a quick look, that the average in each cell is 1 red, 1 black, 2 black, 1 red, maximum 3 black, 1 red, this means that it will not be amplified. What about this light? Is it countable? Is it amplified or not? Countable? Yes. Amplified or not? Amplified. Does it have clusters? Yes. But here the clusters are not present in all of the cells. Yani this cell has cluster, this one, but there are some cells that don't have actually clusters. Yani I might say this is a small cluster, but I'm not sure. But there are other cells that don't show the clusters. For example, here there's no clusters, but there is amplification. Yani there is amplification, there is increased number of the black signals, but the clusters are not present universally in all cells. They are present just in some cells. Like this cell, for example, definitely no clusters here, but the count is increased of the black signals. Okay, is this countable? No, sorry. Heterogeneous? No, not actually heterogeneous. Yani they are rather homogeneous, but yani the amplification just increases in some cells to form clusters and in others not. Okay? Oh, sorry. So what about this? Is it countable? Is it amplified or not? Countable? Yes. Amplified or not? Yes. Amplified. Does it have clusters? Yes, some clusters. Yes, it has some clusters, but also not universal clusters. Like, for example, I can say there's a cluster here, there's a small cluster here, yes, maybe here, but there are others that don't show clusters, just amplified signals, like, for example, here. I'm sorry, the pointer. Yeah. Like down here, this does not mount to a cluster, so it's increased signals, HER2 signals in some cells, but few of them show small clusters. Okay. What about this? Is it countable? Is it amplified or not? Countable? Yes. Amplified or not? Not amplified, that's correct, because the average HER2 to SEP17 ratio will not be actually more than 2 in most of the cases, and also the average HER2 copy number will not be more than 4 if we count, inshallah. Okay. So, unfortunately, these are the easy cases, but the good news is that the easy cases, or the strict positive from negative cases, form around 95% of cases of what we see. The 5% are distributed among the group 2, 3, and 4. Like, for example, in this case, which has a HER2 SEP17 ratio equals 2 or more than 2, but an average HER2 copy number less than 4. I cannot call this amplified because the average HER2 copy number is less than 4. This is the group 2. So what do I do in this case? If I have not done immunohistochemistry in my lab, the case مثلا is referred from outside and the immunohistochemistry is referred from outside, I have to repeat the immunohistochemistry in the lab and see if it's 3 plus positive with protein expression. If not, then I go to my colleague and he counts the slide again to see if it's the same numbers that I have done, the same number of signals. In that case, if it's the same number of signals, then we issue the case at the end as HER2 negative with a comment. Of course, if there's a difference between me and my colleague, then we go to our procedures to see how we can issue the case, my opinion or his. Okay. So before we go to the comment, usually such cases when the HER2 copy number is low but the ratio is increased, sometimes these cases are due to chromosome 17 monosomy. That is, the chromosome centromere signals are reduced, so it gives a false impression that it is HER2 amplified, but the HER2 signals are not amplified. The ratio is just increased, but it's not amplified. And the comment in this case is evidence is limited on the efficacy of HER2 targeted therapy in small subset of cases with HER2 SEP17 ratio equal or more than 2 and an average HER2 copy number less than 4 in the cell, and the patients will probably not benefit from the from the Herceptin or the anti-HER2 antibody. Group 3, where we have the HER2 copy number equal to or more than 6, but a HER2 SEP17 ratio less than 2. We have black signals, HER2 signals that are equal to more than 6, but the ratio has not reached 2. So how do we do with the case? Again, we repeat the immunohistochemistry if it's done in another lab, and if it's not overexpressed by immunohistochemistry, again, another observer sees the slide and recounts, and if it's the same at the end, then we issue the case as HER2 positive because the number of the HER2 gene is more than 6 per cell. And sometimes, in these cases, there is chromosome 17 polysomy. It's increased the number of the centromere signals, which gives a small ratio at the end. And we also give a comment that there are insufficient data on the efficacy of HER2 targeted therapy in cases with HER2 ratio less than 2 in the absence of protein overexpression, because such patients were not eligible for trastuzumab. When concurrent immunohistochemistry results are negative, 0 or 1 plus in this case, it's recommended that the specimen be considered HER2 negative. So we go to group 4, which is what is the appropriate diagnostic workup for the invasive cancers with an average HER2 copy number between 4 and 6 and a HER2 SEP17 ratio less than 2. Initially, this was considered an equivocal HER2-ish result. In these cases, also we repeat the immunohistochemistry, another observer sees the slide, and if it's the same result, then we issue the case as HER2 negative with a comment, and the comment would be, it is uncertain whether patients between HER2 copy number 4 and 6 average HER2 signals and HER2 CEP17 ratio less than 2 benefit from HER2 targeted therapy in the absence of protein overexpression, and we may need to repeat the test later or another biopsy to make sure that it is amplified. Okay, so this reflects the biology of the 5-ish groups. Number 1, the classic HER2 amplified. Number 2, usually due to monosomy of 17. Number 3, group 3, usually due to co-amplification, previously polysomy 17. Number 4, borderline equivocal. And number 5 is the classic HER2 negative or non-amplified. And as I said, these difficult cases, they represent, fortunately, less than 5% of what we see in our practice. The heterogeneous, there was a question about the heterogeneous HER2-ish staining. This happens when you have two populations, one that is non-amplified and another population, a different population that has amplification of HER2 signals. We usually go with the area that is amplified if we can count 20 separate cells, but if this area is less than 10%, we should report this. Sometimes, of course, it might be more than 10% in the excision specimen, but, we should report if it's less than 10%, the area that has, I'm going the other way, I'm sorry. Okay, so we should report this in the reports, okay? And the sample pathology report should be like this. Of course, the diagnosis, the grade, which is very important, the immunohistochemistry results, and the HER2 in situ hybridization, whether it's negative, positive, or not amplified, indeterminate, we cannot determine, and we have to explain the cause, and we will see examples of this later. The number of observers that have seen the slide, the number of invasive tumor cells counted, if it's a dual probe assay, and that's of course preferable, we have to state both the average number of HER2 signals per cell and the HER2 CEP17 ratio, and also mention if there is any polysomy or monosomy, heterogeneous signals. Okay, and in case of heterogeneous signals, percentage of cells, as I said, with amplified HER2 signals. A quick tour in the quality assurance, because that's very important in the HER2, whether the immunohistochemistry or the ISH, we have to make sure we have the proper pre-analytic testing and reporting conditions, and the validation of the kits used for the testing, that they are fit for the purpose they are made for. If they are FD approved, better of course. If they are FD approved, the lab has to have its standard operating procedures to standardize the process, the training of the personnel and the competency assessment, external quality assessment or proficiency testing, regular audit by measuring our numbers, our cases, our positive cases, our amplified cases. We have to do that homework to make sure that we are in the acceptable range. Repeat of HER2-ish testing, if it's the case is not acceptable, I have to repeat it. It would not be acceptable in case the controls are not as expected. I'm talking specifically about the internal positive controls, because each slide would have at least a lymphocyte or stromal cells, endothelial cells. Observer cannot find and count at least 2 areas of invasive tumor. There has to be at least 2 areas of invasive in the tumor in the slide to count. More than 25% of signals are unscorable due to weak signals. The signals are weak, I cannot see it. More than 10% of signals occur over the cytoplasm, and of course they should be in the nucleus, and if the nuclear resolution is poor. Note that a certain percentage of slides, not more than 6%, still may need to be restained due to slide drying and or other artifacts. Yani, the only test that proficiency test from the CAP that comes with extra slides that are not supposed to be stained, they are supposed to be substitute slides, is the ISH, because it's acceptable in a certain percentage that the ISH testing will fail, and I might repeat the test. Okay, so we should report HER2 test result as indeterminate if technical issues prevent one or both tests, immunohistochemistry or ISH, from being reported as positive, negative, or equivocal, and these conditions may include like specimen handling, artifacts, analytic testing failure. Several problems may happen. In this case, another specimen should be requested for testing to determine the HER2 status. These are examples of cases that need to be repeated. Of course, we can see here that the signal is spread outside of the nucleus, over the cytoplasm, and even outside of the cell. Sometimes there is excessive bubbling of the cell. I cannot see separate cells, and it's very hard to see separate cells. The cells are overlapping one another. In this case, also, the signals are blurry, especially the chromosome 17 signals, and many of them are in the cytoplasm. Here, what's known as the silver dust, where the HER2 signals, instead of forming signals like this, they are spread as dust all over the nucleus and sometimes inside the cytoplasm and outside the cell. So all these cases should be repeated. Here we have some weak signals, we have some signals that are countable here, but in other areas it's very hard. We have weak signals, so I might have hard time counting 20 cells. This case is an in situ case, so of course we do not count the in situ. This is the ductal carcinoma in situ with comedo necrosis. We count the invasive tumor. As I said, audit is necessary. We should measure our numbers of HER2 positive cases and ISH positive cases and compare it to what's published in the literature, to what we have been doing last year and the year before that. And it's very important to do correlation with the histologic type and the grade of the tumor. The grade is very important, because if I see that a grade 3 carcinoma is negative to everything without proper internal control, sometimes I question myself. Yes, it can be triple negative, but I have to make sure that it's not, for example, HER2 positive, by having the proper on-slide control, and also, of course, for the ER and PR, if we can find internal controls. So we have to correlate with the grade of the tumor, and it's mentioned in the guideline that if I have a grade 3 tumor that is HER2 negative, I may repeat the test on the excision specimen later, or on a metastatic biopsy from the metastatic site. We finish here by highlighting the importance of the cold ischemia time, highlighting the type of the fixative neutral buffered formalin that we should be using, and it should be immersed immediately upon collection, and the duration the tissue stays in the fixative. It's usually between 6 and 72 hours, but it's best if we can keep it for at least 12 hours before it is processed. 24 hours is optimal, and the volume of the formalin should be enough. Usually the formalin is enough in the collecting container, because it's a 1 biopsy and he puts it in the container. But there comes the issue when we put them in the cassette holding container. We have to make sure when we put the samples in the cassette holding container that we have enough volume covering the cassette, minimum 5 times, and of course the optimum is 15 to 20 times the volume, and also the sectioning using the proper positive slides and the temperature of the drying oven. Here is a picture showing different fixation durations, and we can see here that the best signals are seen in the 24 hours duration of fixation. So that's very important because, as Dr. Nadia Mukhtar, my dear professor and mentor, said, tissue is the issue. Thank you, and I end here with a prayer for يعني إخواننا في غزة، ربنا يا رب ينصرهم وينجيهم. Questions, or we move to the workshop?
Thank you, Dr. Iman, for this amazing lecture. You are great as usual.
بسم الله الرحمن الرحيم. Now Dr. Marwa Abdelkader, the lab director of Cancer Center of Dar es Salaam. Dearest Marwa, تفضل. Interpretation of HER2 ISH testing of breast cancer cases.
Hi everyone. Our workshop will be interactive workshop, but before that we will quickly summarize the ISH interpretation after detailed informative lecture of Dr. Iman. As all of us know, ISH interpretation should be done on HER2 score 2 cases to detect if it's amplified for ISH or not amplified for ISH. The 4 basic steps for ISH interpretation is first to check normal internal control cells, which is lymphocytes, endothelial cells, or then we locate an invasive carcinoma with innumerable tumor cells. After that, we count the HER2 and the chromosome 17 signals in at least 20 nuclei. Then we calculate a ratio, HER2 chromosome 17 ratio. First, we will show the internal control cell, which is fibroblast, lymphocyte, endothelial cells, or even the normal breast epithelium or myoepithelial cells. Each cell should have a normal copy number of HER2 and the chromosome 17, 1 to 2 signals depending on the plane of section. Then we will identify invasive carcinoma. As all of us show here is a DCIS, so it already will be amplified and having clusters in ISH study. And then we should count on the invasive cancer, which is here as B, so to detect if it's amplified or not. Then identify innumerable tumor cells. We should select the cells with the highest average number and the representative size. We should select the cells of average size of the tumor cells. Too large or too small cells shouldn't be counted, and we should select the highest average number of cells. As mentioned, if the subpopulation exceeds 10%, we should report it. Again, on the cell selection, we select the highest average number of segments. As all shown here is the highest average, circled by yellow. So we should count on the yellow circles. Don't include much large or much small cells. Always select the average cells of size of carcinoma nuclei. Don't include nuclei that contain weak signals. Don't include compressed or overlapped nuclei or necrotic area. And also don't include nuclei with excessive background. So what should we count and what should we don't count? We should count here, this cell, we should count as one black and one red signal. The second one, there is 2 black signals and 2 red signals. So we will count 2 black and 2 red signals. The last one, we will count black as 1, and we will count red as 2. We will count black as 1 even it is doublet, because it must be the distance between the 2 signals is equal or greater than the diameter of the single signal. So it's 1 black signal here, 1 black signal here, and 2 red signals. Don't count if the nuclei are overlapping. Don't count if no signal present in the cell. Don't count if only a signal of one color, only red signal, then should be repeated. Don't count if there is signals outside the nuclei. About counting clusters, small clusters will be counted as 6. Here we have a small cluster and 2 signals, so this will count as 8. Large clusters, and small or large is depending on the size of the cluster. Large clusters will count as 12, and here we will have this clusters large as 12 signals and 4 other signals, so it will count as 16 signals. Don't count if the clusters are obscuring the red signals, then we should magnify at 60x, otherwise don't count. So after that, we will calculate in the report. As all of us know, HER2-ish should be very accurate to detect HER2 positive breast cancer, so they can benefit from the highly effective anti-HER2 therapy. On scoring, they are divided into 2 main categories. If the HER2-CEB ratio is more than 2, and if the HER2-CEB ratio less than 2. If the HER2-CEB ratio more than 2, so we will go for the HER2 copy number. If the HER2 copy number more than 4, so it's group 1 positive. Okay, if the HER2-CEB ratio, chromosome 17 ratio, is less than 2, then the copy number less than 4, it's go to group 5 negative. And this is the most common groups in our practice. Group 2, group 3, group 4, the gray zone is accounting for less than 5% of cases. And we will show them if HER2-CEB ratio is more than 2 and the copy number is less than 4, so it's categorized as group 2. If the HER2-CEB ratio is less than 2 or copy number more than 6, it's categorized as group 3. And if the HER2 copy number between 4 and 6, it's categorized as group 4. And these 3 groups require additional workup. Additional workup to first return back to the HER2 stained slide and count in the same area that I localized that HER2 is score 2+. And if it gives the same result, I will reassess with another pathologist to detect the final decision. So to summarize, HER2-CEB ratio more than 2 and HER2 copy number more than 4, it's group 1 positive. HER2-CEB ratio is less than 2 and HER2 copy number is less than 4, it's group 5 negative. And the other 3 groups, if HER2-CEB ratio more than 2 and copy number less than 4, it's group 2, and after additional workup, it is negative. If the HER2-CEB ratio less than 2 and HER2 copy number more than 6, it's group 3 and it's considered positive. Just the amplification of the black signals is masked by the amplified red signals. So it's group 3 is considered positive after the additional workup. Group 4, if the HER2-CEB ratio is less than 2 and the HER2 copy number between 4 and 6, and it's considered negative. So returning to our interactive workshop, we have a 5 set of cases. We'll divide it into 5 groups. Each group will show 1 set of cases, and we'll record on this table. And after finishing, you will discuss the results. Dr. Miller.
السلام عليكم. احنا هنبدأ يعني نشوف الميكروسكوبات، بس علشان يبقى الدنيا منظمة هنبدأ مثلا بأول صفين يقدروا يتحركوا معانا ويتفضلوا.
حاضر. ال H&E هنا باين في عندنا high grade carcinoma شكلها poorly differentiated. very minimal ductal differentiation، وطبعا واضح عندنا في pleomorphism. ده ال H&E. نبص على الاميونو بتاعها. فوكس يا مرو. طبعا باين هنا ان هو في complete membrane staining وفي اكتر من 10%، بس الستيننج مش strong، فعشان كده هي equivocal. لازم زي ما قلنا الاميونو سلايد دي بتبقى الجايد ماب بتاعنا، فاحنا بنبص على الحتت اللي هي فيها يعني الكومبليت واللي هو relatively يعني staining moderate، ما يبقاش weak قوي يعني، ونبص عليها في السيش. يعني مثلا مش هبص على اللي هم الكوردز الرفيعه دي، انا هبص على الشيتس اللي هم الجنب بعضهم دول، فدول هدور عليهم في السيش. دي الحتت الكورز اللي قلنا يعني هنتجنبها شوية، بس نبص على اللي هم الشيتس أكتر. طبعا أنا مش هقول طبعا. ثواني بس أكبر لهم ثواني بس أكبر لهم البتاع دي اهي. بحاول بس اظبط الفوكس. باينه يا جماعه؟ يعني عندنا في separate cells باينه، هي طبعا الميكروسكوب باينه احلى الحقيقه. بس يعني في اولا عندنا internal control السترومال سيلز واخده في هناك على الناحيه اليمين. الانترنال كنترول على الناحيه اليمين واخد، وعندنا السيلز في separate cells يجيب 20 يعني، والكلاسترز طبعا هنا سوبر كلاسترز، هنا ميجا كلاسترز، يعني ممكن السيجنال هنا تتحسب ل up to 24 سيجنال، علشان على حسب لو قلنا الريفرنس بتاعنا هو النورمال سيل، فشوفوا الكلاستر يعمل قد ايه من النورمال من النورمال سيجنال، من الريفرنس سيجنال بتاعت النورمال سيل. فهنا طبعا يعني بنتكلم على فوق ال 20 السيجنالز كده. تمام، فدي كده امبليفايد. نشوف حاجه ثانيه والكلاسترز طبعا. مش قادرين نقول قوي لو ولا هاي جريد، فهيبقى هنشوف الهير 2 هيطلع ازاي. طبعا في شويه سايتوبلازميك ستيننج بس ستيل في عندنا ممبرين ستيننج بس مش سترونج وكومبليت. عندنا سايتوبلازميك ستيننج بس ستيل عندنا في ممبرين ستيننج مودريت وفي اكتر من 10% من الخلايا. نشوف نفس الخلايا دي بقى كده ونبص عليها في السيش. نفس مجموعة الخلايا اللي احنا كنا شايفينها هناك. مش هتكلم بس انتوا قولوا لي كده الامبريشن بتاعكم ايه. انا هحاول اجيب بس هاير باور معلش. حاولوا تعدوها يعني كده بسرعة. هو في بوينتر؟ فيش خلاص خلاص طيب تمام. بصوا هي فيها حتت فيها سيجنالز زيادة بس طبعا هي دي محتاجة تتعدي. يعني قول لنا يا مروة دي كانت ايه؟ يعني هي كانت بوردر لاين. اروح بس على الشاشه عشان في حاجه صح في ده. اوكي ماشي برافو كويس تمام كويس قوي. يعني هو انا كان قلقني بس ان في عندي حاجات تشبه الكلاسترز زي مثلا هنا كده بس برضو لو جينا نشوف الريفرنس سيل ونشوف السيجنال في ريفرنس سيل زي دي سوري ريفرنس سيجنال هنبص نلاقيها دي ما تعملش برضو 6 مرات قدها. يعني هتعمل مثلا 4 مرات بالكتير. فاحنا عندنا الدوبلتس زي هنا مثلا تعدي 1 يبقى دي هيبقى فيها 3 HER2 سيجنالز و2 سب17 سيجنال. ده برضو مش هحسبه كلاستر لان زي ما قلنا لو خدنا الريفرنس ده ما يطلعش 6 مرات قد السيجنال دي او يعني هاردلي ممكن. لكن معظم الحاجات بنتكلم ما بين 3 2 HER2 سيجنالز 2 HER2 سيجنالز وطبعا 2 هنا 17. بنتكلم من اول 2 ل 4 سيجنالز في معظم الحاجات. عندنا من 2 ل 4 سيجنالز with the exception of حاجات قليله قوي اللي ممكن اقدر اقول ان فيها اكتر من 4 HER2 سيجنالز او فيها ما يشبه السمول كلاستر زي ده بس ده مش متكرر يعني. فلما اتحسب الافريج يعني دي من الحالات اللي هي مش من الاول نظره كده نجيبها طلع ان هي مش امبليفايد يعني. نشوف حاجه كمان. الحالة دي يعني ممكن كده الواحد محتار دول يعملوا 10% ولا لا، بس ساعات احنا بنديها the benefit of the doubt ونعمل لها سيش. amplified or not amplified. دي باينه انها not amplified، لان احنا لو بصينا هنلاقي في اغلب الخلايا it's either دي دوبلت على فكره تعد واحده لان لازقين في بعض، وواحده بالكتير قوي يعني برضو هنا في دوبلت فاتنين واحد، هنا اتنين اتنين. طبعا زي ما قلنا لما بنعدش الخلايا اللي لازقه في خليه تانية بنعد اللي هم السيبريت سيلز، يبقى البوردرز كلها كده وما تبقاش ترانكيتد، ما تبقاش يعني مثلثه ولا مربعه. ده 2 1 هنا، ده زي ما قلت مش اي حاجه شكلها irregular نقول عليها كلاستر. احنا الريفرنس بتاعنا دايما بيبقى النورمال سيجنال اللي موجوده عندي في النورمال سيلز. يمكن هنا مثلا مش باين قوي نورمال سيل في الفيلد ده، بس لو بصينا على السيجنالز بقيه السيجنالز هنلاقي مثلا ان ده يعمل منها مثلا 3 بالكتير 4، ما يعملش 6، فده ما نحسبوش كلاستر. وده هنا كده 2 1. دي ممكن تبقى نورمال سيل على فكره، يعني دي ممكن تبقى حاجه اندوثيليال سيل مدوره اوفل او ليمفوسايت حاجه كده. 2 1 2 2 1 1. فالافريج بتاع اغلب الخلايا النيوكلياي not more than 2 او بكتير 3 هيرتو سيجنالز والكروموزومز 1 or 2، فهيبقى الكوبي نمبر مش هيجيب الاربعه والريشيو غالبا مش هيعدي كمان ال2. فدي هتبقى الجروب اللي هو انه واحد بقى جروب ايه ده؟ جروب كام؟ 5 اللي هو كليرلي نيجاتيف، واحد الكليرلي بوزيتيف وخمسه الكليرلي نيجاتيف اللي هو بيبقى الريشيو اقل من 2 والكوبي نمبر اقل من 4. غالبا اللي شفناها هناك عملت كده. دي فيها منظر الكيرفي فورم وشكلها هاديه كده، فيو اكسبكت يعني باللي هو الكورليشن ان هو غالبا دي ما تبقاش هيرتو بوزيتيف، بس هنشوف برضه لازم طبعا نشوف ونعد ونشوف الاول immunohistochemistry. طبعا باين برضو الممبرين ستيننج بس مش سترونج كومبليت ومش سترونج وفي اكتر من 10%. نبص على السيش هنشوف كده. تمام، رأيكم دي تبقى ايه؟ amplified ولا مش amplified ولا محتاج عد؟ محتاج عد. محتاج عد. في حاجات فيها 4 مثلا، يعني دي فيها 4 هيرتو سيجنالز وفيها الريد سيجنالز 2، وفي حاجات فيها 3 زي دي. في هنا دي 2 سيجنالز، دي هنا فيها 2 سيجنالز برضو. دي فيها كلاستر، ده ممكن نقول على ده كلاستر، يعني ممكن ده يبقى سمول كلاستر. بس هي يعني هي غالبا دي هتبقى من الحاجات اللي هي الاكوي اللي هي ان بتوين اللي هتحتاج تتعد مرتين. يعني هي دي احنا عديناها هناك، وكان لما عديناها على الميكروسكوب طلعت نوت امبليفايد، كان الريشيو بتاعها بوردر لاين، لكن الكوبي نمبر كان 3 مش جايب 4. لما اتعدت قبل كده كان الكوبي نمبر اللي هو ده 3.8 ولا ده 4 كان around 4 والريشيو around 2.8. فهي طبعا الحاجات اللي هي في النص دي بتبقى فيها variation. فدي محتاجه ان هي بقى يعني لو في اختلاف في الاوبينيون على حسب بقى اللاب، هيشوف مثلا لو عنده حد اكسبرت بيشوف السيش فهو هيعتمد راي الخبير في السيش، بس طبعا بعد لما يعمل الاميونوكيمستري لو هي معمول لها بره يعيدها، لو هي معموله في اللاب نبص عليها تاني نشوف الكنترول بتاعها ايه، هي اكسبرست ولا لا، لان دي من الحاجات اللي هي صراحه ممكن حد يعدها وتبقى يا دوبك توصل لغايه الاربعه، لان هنا مكتوب كده around 4، واحنا لما عديناها هناك كانت 3 او 3 بوينت حاجه، وكان الريشيو معدي الاثنين بحاجه بسيطه. فدي من الحاجات اللي هي مش ستريت لا جروب 1 ولا جروب 5 يعني. فيها ايه؟ ريد سيجنالز مالها؟ 3 ريد سيجنالز دي بوليزمي. ما احنا قلنا ان في حاجه اسمها بوليزمي، ان هي والبوليزمي ده ممكن يقلل الريشيو، يعني يبقى عندي الكوبي نمبر عالي بس الكروموزوم فيه بوليزمي، فيبقى هو يقلل الريشيو. وممكن ما هي دي ميزه بقى ان هو ان احنا بنعمل دول بروب، ان احنا بنشوف النمبر بتاع الكروموزوم والنمبر بتاع السيجنالز. يعني مثلا دي لو بتتعمل بسنجل بروب اللي هو مش دول بروب بيقيس بس الهيرتو سيجنالز هتطلع امبليفايد. ليه؟ لان النمبر اوف كروموزوم زايده فهتطلع امبليفايد، لان مش هعمل ريشيو، انا هتطلع عندي امبليفايد لان الكروموزوم زايده. لكن انا لو حسبت الريشيو لا، انا محتاجه بقى في الحاله دي علشان لو الريشيو اقل من 2 ان انا ابقى معديه الكوبي نمبر الافريج اكتر من 6 عشان اقدر اقول عليها بوزيتيف، اللي هي جروب 3. اوكي، لا مش شرط يبقى في كل الخلايا، مش شرط في كل الخلايا، بس يعني يبقى في significant amount، يعني في significant population عشان تقدر تقول ان فعلا دي فيها بوليزمي. نعم، لو هو significant ممكن تقوليه طبعا في الريبورت. معنا حطيت في السامبل باثولوجي ريبورت اللي هي الانوزومي، بتقولي اذا كان مونوزومي ولا بوليزمي، بس لو هو significant مش في خليه ولا اتنين، لان خدوا بالكم برضو ممكن لو هو في خليه او اتنين يبقى دي حاجه ليها علاقه بالبريباريشن يعني ريتريفل، الحاجات دي ممكن تعمل المشاكل دي. نشوف حاله كمان في وقت. تمام ماشي. دي معمولة على lymph nodes. lymph nodes فيها metastasis. lymph node فيها metastasis. دي برضو يعني border line 2 plus يعني كده، يعني ال complete membrane staining hardly يجيب ال 10% يعني، بس هي بص عليهم بقى بالقش. دي طبعا باينه فيها كلاسترز. طيب تعالوا بقى نبص على خلايا مثلا الليمفوسايتس ونشوف الريفرنس، نشوف في حته مثلا فيها ليمفوسايتس. انا بس هشوف حته فيها ليمفوسايتس، هنشوف الريفرنس سيجنالز. شايفين الفرق ما بين السايز بتاع السيجنال في الليمفوسايت قد ايه والكلاستر قد ايه. فده هنا يعمل 6 تايمز، يعني هنا بسهوله يعمل 6 تايمز. هنا ممكن اشك، بس يعني هنا برضو ممكن اشك، بس طبعا في هنا definitely 6 times more يعني اللي هو فارق عن الليمفوسايتس. وفي كمان large clusters يعملوا 12 و even 18 سيجنال من اللي هم بتوع الليمفوسايتس. معظم الخلايا فيها كلاسترز. انا كنت بدور على حاجه يكون فيها كوبي نمبر يتعد، بس هي معظم الخلايا هنا عامله كلاسترز. نعم. هو ساعات على فكره بيغطي، بص الكلاسترز بتغطي الاحمر، بس انا بشوف الخلايا اللي هي اللي مبيناه، لو اطمنت ان هو موجود خلاص يعني. يعني لو موجود في بعض الخلايا، وبعدين موجود عندك في النورمال سيلز. ف نعم. بصي في العادي انا بقول اكتر من لما بريبورت بقول ان هي بوزيتيف امبليفايد، وبين قوسين كده ان الهير2 كوبي نمبر اكتر من 6 والهير2 سب 17 ريشيو اكتر من 2. بس لو حد عايز يعد ممكن يقول، يعني دي انا ممكن لو هعدها، لان لو جالك مثلا في البروفيشنسي تيستنج بيطلبوا منك العد، فانا بحسب بقى بالاكزاكت نمبر، فانا بحسب بقى بالسايز اوف ذا كلاستر قد ايه هو مضروب، يعني 6 مضروب في قد ايه، فالاصغر كلاستر هو 6، واشوف ده بقى ايه مضروب في مرتين ولا في 3 ولا في 4 وكده. فهو هنا الافريج بتاع السايز اوف ذا كلاستر ده تقريبا اللي هو هيبقى حوالي 18، يعني لان هو تقريبا 3 اضعاف الكلاستر الصغيره، يعني من 2 ل 3، في بعضهم يقول 12. دي السمول كلاسترز اهي، زي هنا اهي شايفين اهي جنبها واحده سيجنال اهي، ودي تقريبا 6 لازقين في بعض، فدي سمول كلاستر، يبقى اللي جنبها دي تعمل 12، ممكن واحده مثلا اكبر منها تعمل مثلا 18 مثلا، حاجه زي كده او حاجه زي كده او حاجه زي اللي فوق في الشاشه دي، او دي ديفينتلي تعمل 18، دي كتير. واللي كان بيسأل على الريد باينين اهو، يعني هي ساعات بتغطيهم البلاك سيجنالز، بس هم برضو في كتير قوي من الخلايا باينين الريد سيجنالز يعني. كده اخر حاجه تمام. واياكم، انا بس عايزه اقول حاجه يا جماعه، يعني definitely يعني you're welcome، سواء يعني في معهد الأورام أو في مستشفى هرمل. اللي عايز يجي مثلا يوم ويشوف معانا الروتين، يعني في المعهد ممكن يقول بس من قبلها عشان يبقى في حالات سيش جاهزة، إنما في هرمل كل يوم ما شاء الله في حالات سيش بتتعرض على طول يعني. فيور ويلكم يعني، وربنا يوفقنا جميعا. شكرا. واخر حاجه بس عايزين نشكر يا جماعه دكتوره مروه، لانها تعبت كتير جدا في تحضير السلايدز، وهي كمان يعني سوبرفايزنج ان كل حاجه تبقى ماشيه صح في المعمل يعني. فشكرا يا مروه، ربنا يكرمك.